Thank you for this great talk. We will continue with Anders Bjartell, who will answer the question, what do I want to see in a prostatectomy pathology report?
Okay, thank you very much. Sorry, let's go back. So, the urologist will start here, then we had a view from the oncologist. So, I'm really delighted to give you my view on what a urologist would like to see. I have some disclosures not really directed to my presentation. So, in brief, what we would like to see is if the operation was successful, what is the risk of recurrence, and how should I monitor my patient? So, it's well standardized today what will be written down in a pathology report. This is from the ISUP together with the International Collaboration for Cancer Reporting. I've highlighted in red what I found most important in terms of to estimate the risk of the patient for recurrence and how to treat the patient. Especially, I would like to focus on if there is a positive surgical margin, what is the Gleason grade there? That's not always mentioned. So, if you look at the first risk factor, positive surgical margin, how often do we see it? Well, it's a systematic review. It's not new, but it was about 15%, and it will increase the risk of BCR with about twofold. It's strongly influenced by the surgeon's skills. Less important is if it's an open surgery or laparoscopic or robotic. Then, in Sweden, we collected information in a prospective trial, 4,000 patients, 14 different centers, more like a real-world data, where we found the positive surgical margin rate to be equal between robotic and open surgery, and also the BCR rate. So we also learned that many patients with focal positive surgical margin, they will not have a recurrent disease. So if you then look at the lymph node involvement, what does it mean to the urologist? Well, this is a paper looking at the outcome in patients with positive lymph node involvement, and at the 10-year follow-up, the oncologic outcome measures varies a lot between different cohorts, different studies. There's a huge variation. And this recent study you probably everyone heard about, the randomized trial from Memorial Sloan Kettering Cancer Center, where they looked at the difference between limited and extended lymph node dissection. What they found was that if it was an extended, it was protective in terms of metastasis that they found. There were no difference in BCR rates. So the number of nodes is already been mentioned. The number of nodes that you find is the most important parameter. If you have more than 2 positive lymph nodes, then there's a great risk for recurrence. Then another thing that we often need to handle as urologists is persistent PSA. How often do we see it? Well, usually less than 10% of the patient. In this nice paper from Mandaria and co-workers, they clearly showed the association between persistent PSA and oncologic outcomes in terms of MSS, OS, and cancer-specific survival. And then in other papers also looked at this. In a systematic review, there was a variation between 5 up to 20%, and with a 10 and 15-year follow-up time, here you can see the difference between patients with or without PSA persistent. So it also tells us that even if there is a PSA persistent, well, what we need to do is to immediately think about multimodal therapy and not wait and just observe the patient. So, but there is a lack of prospective randomized clinical trials here. So, looking at the risk of recurrence, this will be discussed a lot later here. Don't only look at what is in the EAU risk model here. Also take other factors into account here, including the positive surgical margin. And then, last week, we published a paper Maybe we can, even before the prostatectomy, estimate the risk of BCR with the new imaging, the multimodal imaging AI-based tool from the Bjartell company. I'm sure the next speaker here, Dennis Brett, will maybe mention that as well. So how should I monitor my patient? The most important thing for urologists? Well, PSA is an excellent tool, but there are no prospective trials telling us how often we should look at it. In the EA guidelines, it says maybe every 6 months or 3 years. I follow my patients more closely the first 2 years, but maybe even longer than 10 years if there is a small positive surgical margin. So, and also, which will be discussed later, when to perform the PSMA PET-CT. So to summarize, I would suggest to look at as many of these risk factors as possible and individualize for every patient. There are clearly literature showing us the association between oncologic outcome and every of these risk factors. So by that, I will leave it for the oncologist to give his view. Thank you.
Thank you, great talk. So now our radiation oncologist on the panel, Thomas Zilli, will answer what he wants to see in a prostatectomy pathology report.
Yeah, good afternoon. Thank you so much for this kind invitation. Great pleasure to give you the radiation oncology point of view for the pathological report. These are my disclosures, nothing related to the presented discussion. So as radiation oncologist, what do I want to see in a prostatectomy pathology report? I think we have 3 open questions. The first one is, should I treat and when? The second one, how should I treat? And of course, how can I personalize the treatment? To give the first answer, when we have a pathological report, we need to assess if we need to propose to the patient an adjuvant radiotherapy. So we consider that the patient is with undetectable PSA, if we need to look at if we have some risk factors that are associated with a worse outcome. We have different normograms. This is one, the Capra score, predicting the risk of biochemical relapse after radical prostatectomy. And we know that for PN0 patient, when we are accumulating adverse clinical factors like ISO grade group 4 and 5, PT3 disease, or even R1 disease, we have a patient that has a risk of biochemical failure. We have randomized clinical trials suggesting that we need to propose to this patient an early salvage. We have the artistic meta-analysis and 3 randomized clinical trials, but we know that when we are accumulating several risk factors, even asking to the panelists of the APCCC 2024, 27% of the panelists continue to recommend an adjuvant radiotherapy when we have a PT3B, PN0, isograde group 4 and 5, and R1 disease. These are different scenarios when we have a PN1 disease in the pathological report. And as discussed before in different presentations, we know that the numbers of nodes is strictly correlated to the worst prognosis. We know based on this retrospective data that with each additional pelvic lymph node positive, we have 8% reduction in all cause of mortality. Looking at the result of the APCCC 2024, again, when we have 1 to 2 pathologically involved nodes, 39% of the panelists recommended an adjuvant treatment, and this rate increased to 61% when we are starting to have 3 or more pathologically involved nodes. The other question, if we decide to observe the patient, we have a biochemical relapse, is to select patient for salvage radiotherapy. This slide is just presented before, but again, we have some risk stratification, some risk groups, and the isograde group together with PSA doubling time is clearly important to select patients that have a high risk of biochemical progression and mortality if not treated with salvage radiotherapy. Concerning the radiotherapy, how to personalize our treatment fields. Certainly surgical margins, the status and the site is really important for us to define our treatment fields. If you have just a R1 disease, probably the disease is just located in the prostate bed. You have to treat just the prostate bed with salvage radiotherapy. If you have an R2 disease, a macroscopic relapse, probably you can consider to perform a restaging using multiparametric MRI, PSMA PET-CT, and consider to boost the disease. And of course, the site of extracapsular extension, the seminal vesicle invasion are really important for us to define the treatment volumes, including the posterolateral margins, to pay attention to the apex treatment or include the seminal vesicles. Concerning the PN status and the node positivity sites, this is also important for us as radiation oncologists because we need to consider for each patient if we need to include or not the elective nodal irradiation. Certainly when we have a PN1 disease in the post-op setting, this for sure that we need to include the whole pelvic radiotherapy. In the salvage setting, probably we have to consider the PSA, the relapse, but also the extension of the pelvic lymph node dissection, and when we are starting to have a limited lymph node dissection with a PSA of more than 0.3 based on the RTOG 0534 data, probably we need to treat also the pelvic node in these patients. It's important, the pathological report, also to discuss the role of androgen deprivation combined with radiotherapy. Certainly for PN1 patient in the adjuvant setting, we need to combine with a long-term ADT, 24 months. In the salvage setting, we have this recommendation from Estro, suggesting 6 months when we have just an isograde group per 4 with a PSA of less than 0.7. And when we are starting to have a detectable PSA with more than 0.7, isograde group of 4 and more, and of course a life expectancy of more than 10 years, the recommendation suggests to use a long-term ADT. What about immunohistochemistry? So there are retrospective data suggesting that PTEN loss is associated with adverse prognosis after salvage radiotherapy. So probably this suggests hypothesis generating, but if we have this element in our pathological report, we can consider the need for treatment intensification, which kind dose escalation with radiotherapy, ADT use, RP, I don't know, but it's just hypothesis generating. Of course, this the future. We will have a genomic classifier that will certainly help us to answer the many questions that we have as a radiation oncologist in terms of timing, use at ADT, and also dose escalation. So in conclusion, I think that the use of standard histopathological report using the risk factors that we know, PT3, PT4, PN1, isograde group 4 and 5, and R1, is clearly essential to guide post-op radiotherapy and to decide in adjuvant versus salvage setting. I think that detail histopathological mapping of disease burden is really helpful to help us as radiation oncology in the radiotherapy delineation and planning. And of course, we will personalize our treatment in the future using genomic classifiers and AI-based predictive models. Thank you so much for your attention.